Hello, this is Dr. Hal Stewart. I'm a restorative dentist here in Flower Mound, Texas, just north of Dallas, Texas. I want to welcome you all to our webinar today, and I'm very flattered and honored that you've chosen to spend your Thursday afternoon for the next 45 minutes or so with me. You'll see the picture on your screen and the title, Full Mouth Rejuvenation Utilizing Composite Resins. A win-win-win situation. And even though that's a picture of my 12-year-old daughter, this is not about pediatric restorations. But when you restore someone's system to a better function and comfort, it really does rejuvenate them and makes them feel and look younger. The reason that I've chosen to share this with you is because in today's economy, many people can't afford full mouth restorations of the entire mouth in porcelain. It's just cost prohibitive. However, composites offer a great way to restore and rejuvenate people's occlusion and give them back the function and health in their mouth. The advantages of composites are many. It's more affordable. It's just a fraction of the cost of porcelain. It's conservative. Many patients have a lot of wear on their teeth, but not necessarily large restorations or breakdown of the enamel, and they would want to preserve as much of their enamel as they can. Composites allows us to do that. It is a valid long-term treatment in many cases as well. It's healthy for the patient, it's profitable for the dentist, and it's very satisfying. I love my lab techs. They do great work. They make beautiful porcelain restorations, but sometimes it's just fun to do it with my own two hands. And composites allows me to do that. It's very rewarding. And eventually the lab technician will do the porcelain work, because many of these cases the composite allows the system to function, and then we can phase in porcelain over a period of time. So who wins? The patient obviously wins. They get a superior restorative product. They get their system restored properly at a fraction of the cost as what it would cost with porcelain, and in many cases more conservative than with porcelain. There are some of these cases that I do that I recommend composite over porcelain due to the fact that I would have to remove more tooth structure if I did porcelain than I would composite. The doctor wins because it is profitable. You basically look at how many hours it would take you to do a case. You know what your overhead is. You know what you need to be making per hour to make a profit. And you multiply that by the amount of hours that it takes you to do the case. There's no lab fees involved. So it is a win-win situation in that case because it's profitable for the doctor. And eventually, when you phase in the porcelain, in many of these cases, the lab will then be able to make their beautiful porcelain restorations. So we're going to get right to it because we have a lot to talk about in a short amount of time. Feel free to ask questions. I'll try to get to them as we go. I can't promise you because we need to get through this, but I will try to answer your questions. Now, these cases are not the most aesthetic cases that you'll see. I do a lot of those. I'm working on my accreditation for the American Academy of Cosmetic Dentistry right now. These cases are practical and functional. They do look good, but from our critical eye as dentists, we can pick apart these composites when we look at them on a one-to-one shot on a computer screen. However, they're functional, they are beautiful, the patients look great, and the patients love them. So we're not going for AACD accreditation on these cases. This is John, a 35-year-old white male in excellent systemic health whose chief complaints were tooth wear and headaches. He knew his teeth were wearing down, and he has headaches. He has no decay in his mouth, a lot of dental restorations that he had done in the military, but his primary concern was the wearing down of his front teeth and his headaches. You can see on the picture on the right, John cannot relax. He keeps his teeth together all the time. This is one reason he has the tension headaches that he has. His neck is cocked, or his head's cocked to the right just a little bit, to his right. You can see there in that picture on the left. The lateral profile shots show a very tense masticatory system. Teeth that are just always touching. It's hard for him to relax. And as the teeth wear down and the vertical dimension closes, the chin protrudes forward as it rotates upward and forward on the arc of closure. So John has an array of restorations in his mouth. He has amalgams. He has gold. He has porcelain. You can see the wear on number 8 and 9 through the enamel into the dentin. Some wear beginning on the canines as well, and on the lateral incisors for that matter. The porcelain is worn through. On the lower, we have gold on 30 and 31, a porcelain crown on 29, a porcelain bridge 18 by 20 porcelain bridge, or I'm sorry, 19 by 20 porcelain bridge. He's missing number 21. And you can see the wear on his incisal edges of his mandibular incisors as well. We take a full set of radiographs. We do a complete exam on John. We look at things like lip posture, phonetics. We look at how his teeth are functioning. You can see he's on a crossbite on his left side. Practically end-on-end occlusion on his anterior teeth. Erosion abfractions on his cervical areas on number 8 and 9. Some on number 11. His right lateral test position, he has no anterior guidance whatsoever. He's in posterior contact. Same thing on the left, lateral test position, no guidance. You wouldn't expect it there with the crossbite anyway. And in protrusive, no anterior guidance either. Like I said, his dental restorations are older, but they were done well. They were done in the military. The amalgams are older, but the margins are sealed, and the gold, the margins are sealed. The porcelain work was done well, but it was done to his existing bite. You can see the cross bite on the left. Look at the wear on the incisal edge of number 11. Very typical of what you see in a case where the posterior teeth have an interference and the patient has to posture forward to get all the teeth to touch. That's exactly what John's doing. The measurement of his central incisor, number 8, pre-op was about 8 millimeters. And the lower central incisor, about 7 millimeters. His vertical dimension of occlusion, as measured from the CEJ of the maxillary central incisor to the CEJ, the cemento-enamel junction of the opposing mandibular central incisor, that's how we measure the vertical dimension of occlusion. We don't measure from the gingival margin because the patient can have a recession or trauma to the area, can recede the gum line. So we want to measure from the CEJs of those teeth. His pre-op measurement was 15 millimeters. Prior to restoring John, his TMJ was stabilized with a full-time, 24 hours a day, 7 days a week wear of an acrylic orthotic. In bioaesthetics, we call this orthotic a maxillary anterior guided orthotic, or a MAGO. Now, I'll back up just a moment. I am on the faculty at OBI, Orognathtic Bioaesthetics International. My primary philosophy of occlusion was formed by bioaesthetics. The founding father was Bob Lee. I have studied extensively at the Pankey Institute and with Pete Dawson as well. I'm a CR guy. I believe the superior anterior medial position is the working position, functioning position of the jaw. This orthotic that John wore was adjusted on a weekly basis to allow for seating of the condyle. Once it was determined that we'd seated the joint in its most superior anterior and medial positions, an open bite was taken. An open CR bite was taken. Trung, well, looks like we don't have any sound. We've had a couple of people say they're not getting any sound, so could we try to take care of that? Unfortunately, the limited time that we have today won't let us go into the art of jaw and joint stabilization. But I would recommend that you find an occlusal philosophy, learn how to find CR, and some great resources for that are, of course, Orgnathic Bioaesthetics International, OBI. The website for that is bioaesthetics.com. The Pankey Institute, the Dawson Institute, John Coyce, Frank Spears. If you don't have a occlusal philosophy, any of those will really get you on the right path. The three most important factors to the success of these cases, this is critical: a stable joint, seated in its superior, anterior, and medial position, so the form of the joint has to be attained. Proper form of the teeth, we build that with our composite, and proper form of the occluded dentition. In other words, we want an overjet of 2 to 3 millimeters. We want an overbite, a vertical overbite of 3 to 4 millimeters. We want anterior guidance with separation of the posterior teeth of at least 1.5 millimeters in excursive movements. So those three factors are crucial. If those three factors are satisfied, you can restore someone's mouth in composite restorations, and they won't break them, and they'll hold up and they'll last. I take my face bows with a Coyce facial plane analyzer. It allows me to situate my maxillary model in the articulator at the hinge axis position, because the Coyce facial plane analyzer was built with the arbitrary hinge axis in mind. So whatever face bow method you use, make sure you mount your maxillary cast with a face bow. In my case, I use a Coyce facial plane analyzer with a Panadent articulator. I have the patient stand up straight. I position John's head. I take that little tilty head to the right out, although he lost most of that when we stabilized his jaw joint with the orthotic as his muscles relaxed. So I make sure that he is level and standing straight, and I take the face bow at a horizontal line that's parallel with the horizon, or at a 90-degree angle with a long axis of John's face. So there he was before on the right. Now his head's straight. I make sure that the face bow is level as well. So there's my level above is level, and the level on the face bow is level. That's how we mount the maxillary model. So now we have an aesthetic plane of occlusion. We took open bite centrics at several different vertical dimensions of occlusion with John. How do we choose the vertical dimension of occlusion? Well, it's an involved process, but I'll briefly go over it here. The vertical dimension, opening the vertical dimension of occlusion in this particular case, allows us to build the proper tooth form that we need. The vertical dimension of occlusion allows for proper form of the bite as well. It allows us to build overbite and overjet. The VDO is comfortable for the patient and aesthetically pleasing to the patient. And the healthy vertical dimensions of occlusion, as measured from the CEJ of the maxillary incisor to the opposing mandibular incisor, can range from 16 to 20 millimeters, give or take a couple of millimeters. So we take several of these bites and we put them in John's mouth. This was the 19 millimeter bite. We take pictures. We let John take these home. He pops them in his mouth and he walks around his house while he's doing yard work or whatever, and he kind of gets used to them over the weekend, and he decides then which one he thinks is the most comfortable. We look at also how he looks in these vertical dimensions. That's 19 and 20. He was a little bit over, he felt like he was over-opened with 20. We decided that 19 was ideal for us to build his bite at. It was the most comfortable for him, and it gave us the best amount of room and the best inter-arch relationship to build the case. So we take an open bite record with using the jig, the 19 millimeter jig, and that's integrity that I'm using there for the bite record because it's rigid. We mount the upper model or the lower model to the upper model at that vertical dimension of 19 millimeters, and then we do a diagnostic wax up. Now, John was a class 3 occlusion or a class 3 inter-arch relationship because of the wear. His jaw had rotated forward and upward on the arc of closure. So as we opened his bite back up on that arc, it moved the mandible down and back, creating more of an ideal class 1 inter-arch relationship. So here's my occlusal stop guide that I use. When I'm waxing a class 1 case, I hang these up in front of my lab bench, and this is the occlusal scheme that I'm going to work with. You see the mandibular occlusal points, occlusal stops, and the maxillary class 1 occlusal stops. I'm going to build those into my wax up. So I'll wax my anterior teeth first at the vertical dimension that we're going to build the case in the mouth. You can see now, instead of end-on-end occlusion, now we have built in 2 millimeters of overjet and 4 millimeters of overbite with John. We still, because of his crossbite, did not have enough room horizontally on the canine, so I had to remove some tooth structure, or in this case, some die stone. I prepped back 2 millimeters and then built it back with 1 millimeter of wax. So in the mouth, we're going to prep 2 millimeters, build it back with 1 millimeter of composite. Still very conservative. You can see I didn't prep the whole tooth, just that lingual spot there where we're going to build the occlusion. So as the wax up progresses, the wax up is crucial. The entire restorative process in the mouth is built from the wax up. So the wax up is crucial. And sometimes I do the wax up, sometimes I let my lab technician do the wax up. If we need to get it done pretty quick, I send it to my lab tech. If the patient schedules several weeks out, I set it on my bench, and during the day when I have a few minutes here or there, I do the wax up. I really enjoy doing my own wax ups. So now we have the back to the premolars waxed. The vertical dimension as measured from CEJ to CEJ is 19.5 millimeters. See all the space that we have to place our restorations now. Checking the anterior guidance. Now we have good canine guidance. Nice protrusive guidance. And anywhere you see wax, that's where composite is going to be in the mouth. Anywhere you do not see wax is unprepped enamel. Very conservative. Right anterior guidance, left anterior guidance. A lingual view of the upper anteriors. Occlusal view of the lower anteriors and the premolars. Here's the final wax up, except for the second molars. Because of time constraints, we restored John back to his first molars, then we came in later and did the second molars. But a patient can function just fine, just premolar to premolar if you needed to do that. But first molar to first molar is just fine for functioning. You don't want to leave the second molars unrestored for too long because you don't want them to hyper-erupt. So here's the wax up from the right, the wax up from the left. You see the wax up from the left, there's a lot more open spaces. That was because of the crossbite that we were having to fix. That's not ideal, but it's certainly very functional. John's not having any problem with it at all. Most of the time, most of the wax ups that I see dentists doing, they wax, the tooth forms are too tight. They don't give enough space. If we back up to the side previously, this is ideal. That's a little bit open, but I'd rather have that those open spaces there than everything being too tight and cramped in. Because that's where patients start clenching and grinding and feeling through proprioception parts of teeth that are almost touching but not quite and kind of locked in. So if we need to err on the side of your wax-ups being a little bit more open like you see on this side. But again, this side is more ideal. And then looking at it from the lingual, you can see a lot of open spaces. Not everything's not just crammed in tight. You really and truly only need to have one occlusal point on each tooth, minimally, and the patient will be comfortable and function just fine. As you saw from the wax-up guide that I showed you earlier, there's more than one occlusal point on each tooth, but minimally one point on each tooth will work. So if you're going to err on the side of keeping it simple. See a protrusive. We've got nice open contacts in the back now. I mean, there's no teeth contacting. Left lateral, we have a minimum of 1.5 millimeters of space on the working side and a minimum of 2 to 3 millimeters on the balancing side, on the non-working side. You can see here on the right lateral excursive, we've got 2 millimeters of clearance on the working side and 2 to 3 on the non-working side. This is a beautiful way to wax a case so that it functions very well and the patient won't break the composite. So now this really illustrates the anatomy. Look at tooth number 18. See how flat that is? Look what we've done to 19. We've suddenly reduced the amount of pressure on this tooth by at least 50% by putting cuss tips on the teeth. Now, how do we get the wax up from the models into the mouth? This is a clear vinyl polysiloxane stent. It's made off of the wax up. This is RSVP by Cosmodent. Another brand is Crystal by Clinician's Choice. Either one of those works great. You make a very accurate impression of your wax up. You let the polyvinyl harden, and then you pop it off your wax up, and now you can take it into the mouth. Now, in the case, many times what I'll do is I will wax the anterior 6 teeth on the upper and the anterior 6 teeth on the lower, and I will take a polyvinyl of that, so I've still got my posterior teeth to act as stops. Then I'll go ahead and wax the rest of the posterior teeth and make another vinyl poly for the posterior teeth. So to the mouth, we're going to use our stent that I just showed you. I'm going to show you another way I make stents in just a moment. We want to pick a shade, which can be done prior to him coming in or the patient coming in for the restorations. This particular case, we use flowable composite on John's anterior teeth. I'm not using flowable quite as much anymore because I'm using Color by GC. We'll talk about that in a moment. But we picked the shade through the shade tabs. We decided on A2. We place it on the tooth, and then we cure it. You want to cure the composite sample on the unetched, unconditioned enamel because sometimes you get a slight change of color when you cure the composite. So cure it. If you don't like it, pop it off and try another shade. In this case, the A2 is what we went with. We pumice the teeth. Now in John's case, on his anterior teeth, we're pretty much veneering the entire facial surfaces. So we're going to pumice the entire facial surfaces and a little bit over to the lingual. We isolate the teeth using, on the right, I used a sari saw. and then clear matrices on the other teeth, just to show you the different things that you can use. You just don't want that etch to get on the adjacent teeth. So you etch every other tooth. In this particular case, we've etched number 22, number 24, and number 26. We rinse, then we condition. We etch the unprepped enamel. Even if you put a slight bevel, you want to etch unprepped enamel for 1 minute. Rinse it thoroughly. Place your adhesive. In this case, I use Solo by Optibon or Avaclar. Optibon Solo. Cure that. Now you can take your strips out because you've cured your adhesive. You place your stent in the mouth. You can see where I've made injection ports with a size 4 or 6 round burr, and then escape ports at the top. So now I go and I inject the composite on those 3 teeth, number 22, 24, and 26. And when the composite starts coming out the escape port, I stop and I cure. So you can see the the flowable composite being injected on the facial, and it comes out the incisal. Actually, it comes out. The escape port is built a little bit lingual. Take the stent out, and we have a rough buildup there of our composite, duplicating the wax up exactly. I trim my interproximals with a barred Parker, and then I finish with ET finishing diamonds, red, yellow, then white, and then final polish with Flexidisc by Composite, and finally Renamelize polish paste by Composite. You want to finish these to completion before you go do the adjacent teeth, or the composite will bond if they're not polished. If they're highly polished, the composite, when you place it on the adjacent teeth, will not bond. So now there's the polished enamel, or I'm sorry, the polished composite on every other anterior, mandibular anterior tooth, and number 22, 24, and 26. There it is. Now we isolate again, and we go through the same procedure. We etch, condition, cure, take the strips out, put your stent back in, inject, and do the other 3 teeth. Now you can see every other tooth, or all the teeth, the anterior teeth, are now completed. And you can see the difference between the roughness that haven't been polished and the ones that have been polished. So now we go and polish the rest of the anterior teeth. And then we start on the upper. I don't want to go back any further now. We want to get our anterior occlusion just right before we start putting posterior teeth in. So I put a bevel on the lingual of my maxillary anterior teeth, where my composite is going to be. We isolate, we etch every other tooth again. We place the stent in, inject the composite, cure it, pull it out, do a rough polish, and then check our vertical dimension. And you can see in this case, our vertical dimension is 19.5, just like our wax up. So we know that we're being accurate with our composite. With transferring the wax up into the mouth, we're being very accurate with this method. And this is important to get the occlusion spot on. So now all we have to worry about is honing the occlusion in on those 3 maxillary anterior teeth. So we go ahead and do that. There you can see the vertical dimension, 19.5, and the wax up, 19.5. So every other maxillary tooth has been done now, maxillary anterior tooth. We hone in that occlusion. You can see we've got our anterior guidance now on the left side, on the canine rise, and we have overjet and overbite. I told you earlier the overbite was 4 millimeters, it's 3 millimeters. Overjet 2 millimeters, and the overbite in this case was 3 millimeters. So now we polish those teeth to completion. We go in and we isolate, etch, condition, cure, take the strips out, place in our stent, inject, and now we have the other 3 maxillary anterior teeth completed. And now we go ahead and hone the bite in, dial it in even more. So now we've got our full anterior occlusion established at the proper vertical dimension with our canine rise, our anterior guidance. The patient feels very comfortable at this point because he's got really, really nice, solid occlusion on those 6 anterior teeth, and that sends very positive messages to the brain that the joint seated, the anterior teeth are in contact. We've got good canine guidance. There are our occlusal stops. And if you remember our occlusal guide earlier that I showed you, this duplicates that exactly because I duplicated the wax up. Now let me show you, just take a break from John just for a second. There's another technique that I use now, and I use it with a more rigid stent, and I'm able to use a composite that's not flowable. This composite is called Colure, and it's by GC America. It's very unique in that it's got a new monomer technology developed by DuPont. It has a patented HDR pre-polymerized filler, and it has a proprietary interface between the fillers and the matrix, making it very, very strong, very wear resistant, and the chameleon effect is incredible. But it's fairly rigid, so what I do is I heat it up, and I need a rigid stent to use this material. So I developed a technique whereas I take my wax up and I take an alginate impression and I pour it up in a hard model, very accurate. I make a Siltec putty that's about 2 millimeters thick all the way around. And then with a BioStar Mini, I utilize the clear 3.0 millimeter BioCryl, and I do a BioCryl stent over the putty. I remove the putty and trim the BioCryl up, and now I have a hard, clear shell with 2 millimeters inside, both buccally, incisally, occlusally, and lingually. Now I take my crystal, after I've painted the tray with vinyl polyadhesive liquid, I put the crystal in, that's a vinyl poly, and I seat it down over the hard model, and now I have a rigid stent, but the inside of the stent is somewhat flexible because it's made out of the vinyl poly. I make now since I'm using Colure, it's not flowable, so I do not make an injection port. All I'm making is escape ports now. So I do that on the facial and maybe on the lingual with a number 6 round burr. Just zip it right through there. You can see there from the inside view. I heat the Colure up with a with a Calcet composite warmer, and I pack the Colure in. Looking at my wax up, I know right where to stop the composite, and maybe just put just a little bit extra. I wrap that in a double bag and I put it in a 180-degree water bath, and then I go into the mouth and I do my preparations and my etching and all that while this stent sits in the water bath. So here's this case. This is not John anymore. This is another case I'm showing you just to show you how I do this stent. This particular patient had no dental restorations whatsoever. He just had worn his teeth down, and he didn't want his teeth cut down to crowns. So we restored him in all composite, and I'll show you his final case at the end of this lecture. one of the caveat in his treatment was that number 24 had been extracted, and his canines, everything had been pulled forward. So his canines were not really in a canine position, nor were they in a lateral incisor position, so we kind of made them hybrids. But so now my stent is sitting in the hot water bath. The composite's staying very warm, and the viscosity is very low now. It's not runny, but it's very low viscosity. So I'll go ahead and bevel. I etch, and in this particular case, since I'm not veneering the entire facial, I'm just going from the incisal edge up. I'm going to go ahead and do all 6 anterior teeth at one time. So now they're etched. I put my solo on. Cure it. I take my stent out of the water bath, out of the bag, go straight into the mouth, and press it down. And remember, I've made the stent. This is the stent of just the 6 anterior teeth. So I've got great stops with my posterior teeth. I set it down. It just sucks right down in there. The composite, the excess composite, escapes out the escape ports. I pull it out, and now you can see the little sprue on the canine there. Most of the time, those little sprues just break off when you pull the stent out, and they just leave a little nub. You can see it there. Then again, you can see it. This is before it was polished. Go in interproximally with a sharp barred Parker. I might use 15 barred Parker blades on one patient during the day when I'm doing these cases, because after you use it a few times, you need to switch to a new one. But this is a very atraumatic way to trim. Very rarely do I even have to anesthetize these patients, because we don't do anything that causes them any discomfort. And even if we do prep a little bit, if it's an enamel, they're not going to feel it. So very rarely are these patients anesthetized, which is good, because when we go to build the occlusion in, they can feel everything. So then we go ahead and trim, and we polish to completion using the ET polishing strips. If I do have trouble getting an interproximally, getting floss through, I might go in with a Brasseler Diamond at 2,000 RPMs, very, very slow RPMs, and pull the lips back with an Optrogate or retractors, and go in there, and very, very lightly I can go in and break the contact, and then finish it out with a Cerisol like you see here. Let's see how well that polishes up. We've got the floss through there now, no catches, rough polish. You can see how we made the canines are kind of a hybrid between a canine and a lateral incisor. Final polish. And this actually blends in better the next day, because the enamel rehydrates. The enamel gets a little bit, after you do these cases, if the composite looks a little dark, don't worry about it, because the enamel just needs to rehydrate for a day or two. So that's how we do it now. I'm using, all my stents are pretty much like the one you just saw now. I don't use just the RSVP or the crystal polyvinyl only. I use it with that rigid shell. Now back to patient number 1, John. We've completed all of his anterior teeth with Renamel, the flowable Renamel. Now I'm going to do his posterior teeth using Colure, and I'm actually going to be using the first type of stent that I showed you, because I did this case several years ago before I came up with this other technique. So we've got porcelain. So what are we going to do with that? Well, we can bond right to it. This bridge is in great shape. No need to replace it. I mean, we will eventually as we restore everything in porcelain, but right now, no need to replace it at all. So we put a bevel with a round diamond. We etch it with porcelain etch, 90 seconds. We rinse. We put silane, dry the silane, and then put unfilled resin on there. I don't need to put Optibond Solo, because we're not bonding to dentin here. So I can just use an unfilled resin like by 3M. And now it's ready for the composite. So the order that when you bond to porcelain, you place your bevel, you porcelain etch for 60 seconds, or 60 to 90 seconds. Then you rinse that off thoroughly. You place your silane. I place silane, I rub it on there for 30 seconds, and then I dry it. Place your unfilled resin, then cure it, and now you're ready for composite. So I use the water bath, but it's the old kind of stent, just the pure vinyl poly stent. And it still works very well. I just like the new stents that I'm doing now, the rigid stents. So there's the little escape sprues where the composite escaped out the sides. And we trim it up. You'll see the final product in a minute. On the other side now we've got gold and porcelain. Number 30 is gold, number 29 is porcelain. So we bevel the porcelain, we bevel the gold, we put retention spots in the gold. I just do that with a number 4 carbide burr, just a bunch of little retention dots. I go ahead and etch the porcelain in. Why not? Let's etch the gold too. It'll clean it up and make it nice and clean and we know we got a good fresh surface. Now what I do with gold and sometimes amalgam is I'll go in and put a little bit of flowable composite. We've etched the enamel or the porcelain and we've conditioned it. We're ready to go in with our stent. I'll put a little flowable composite in the little potholes, but I won't cure it. I want it to stay uncured. Then I put my stent in, and now we're ensured that we've got composite down in those potholes. When we cure it and pop it off, this is what we end up with. Very little trimming has to be done on this. So now we've got our entire lower arch done, with the exception of the second molars, which we went in and did later. We've got occlusion on our 6 anterior teeth. Now it's time to do the upper posterior teeth. Here's another view of the lower arch. You can see the cusp tips on the posterior teeth, as opposed to the flat anatomy that we had before. And there's the lower right side. And the lower left side. Now in this particular case, the lower left side didn't take much time at all because there was no interproximal contacts we had to open up. But opening up interproximal contacts is not a problem as long as your stent is very accurate and the polyvinyl material gets into those embrasures really good. You don't have a lot of contact. It's not hard to open the contacts at all. So on the upper, we bevel the gold, we bevel the porcelain, bevel the amalgam, put some retention grooves in the porcelain, in the gold and in the amalgam. We don't need to put retention grooves in the porcelain because we're going to chemically bond to that. We've got, on number 4 there, we've got some enamel and dentin that we can bond to as well. On the other side, we have a huge amalgam buildup on number 14 with a chip out of that one side, so we've got a little bit of enamel and dentin to bond to there. So just put a lot of big retention pits in it. Put some retention grooves down the middle of the amalgams on the inside of the premolars, and we've got a lot of enamel to bond to on the premolars as well. So we're going to have a lot of good retention there. So here's the entire upper arch. You can see both sides are prepped now, with the exception of the second molars, with our bevels and our retention grooves. The maxillary anterior teeth are completed. And here is the final case done in color. Just using that same technique of heating the composite up, placing it in the stent, placing the stent in a water bath, doing my preparation on the teeth, and then coming straight in with the stent. On John, we did one side at a time. We could have done both sides at one time on his posterior teeth if we had wanted to. I just like to keep it really to no more than about 2 or 3 teeth at a time. That's just my comfort zone. So before with preps, with the amalgam and the gold prepped, and afterwards after we've restored in composite. Mandibular arch before, mandibular arch after. Before and after. Peter asked a question, how long in the water bath? In the water bath, usually no more than, just because it doesn't take me that long to do my preps and bevels, it's usually in the water bath. I'd say a minimum of 10 minutes. It's already heated because I heated it in a composite warmer. So it's already heated. So I would make sure it stays in the water bath at least 10 minutes. And we do make the potholes on the gold. So that is one thing that we need to tell the patients. It's not completely like we can, if they decide they don't like this, which they never do, but you're not going to be able to take that composite off and have that nice smooth gold there anymore, because you do have to make potholes in the gold. So you need to let the patient know that. So here's the final case. Before we had end-on-end occlusion, a left crossbite, and no anterior guidance. Now we have 2 millimeters over jet, 3 millimeters over bite, no crossbite anymore, and anterior guidance with complete posterior disclusion in excursive movements. Left excursive, right excursive. Here's the tooth form afterwards. This is immediately upon restoring. We restored John in 1 day. He was very easy to work on. I've done a lot of these cases. I normally do the lower arch 1 day and the upper arch the next. But in John, because of time and different issues, we did the entire case in 1 day. On the posterior, I normally, like in John's case, I normally do, if I'm doing all 4 posterior teeth, I'll do the premolars together and the molars together. In John's case, since this particular appointment, we were just doing premolars and 1 molar, I went ahead and did all the posterior teeth at one time on each side. So I did the right side, then the left. So you can see from the side before and after. Look at the tooth form. Those cusp tips now chew very efficiently. He's got very pinpoint occlusion on each one of those cusp tips with the opposing teeth. Very, very positive signals sent to the brain. The anterior teeth touch as well. There are no interferences posteriorly in his arc of closure because we stabilized the joint and we built the case at a CR position. Here's the left side. Remember, the left side's more open because of the crossbite, but it still functions very well. So here he was before with a crossbite and afterwards. And look at the difference between the occlusion, the occlusal form on number 19 versus number 18. And you can ask your 3-year-old daughter or son which one of those teeth would chew food better, and they would get it right, I'll bet you, 100% of the time. So before and after. And remember, this after picture was taken after John had been in my dental chair for 5 or 6 hours. Still looked pretty fresh. And there he is afterwards. He's got relaxed muscles, a nice full smile. He was absolutely thrilled. Look how much more relaxed he looks. His chin doesn't jut out as much because we've opened his bite up some. I'm not seeing all of the questions. They kind of fade out, but Nicole asked, can this be performed by, I'm assuming you're saying by a general dentist, and the answer is yes. With the proper training, absolutely. So these are not always the most beautiful cases when viewed with the critical eye that we have as dentists. However, the patients love it, and they look very good from a social distance. Even from a close-up distance, they look great. Most importantly, they're very practical, and they're functional, and they're affordable. Now, John can phase in porcelain as he wishes, and he can do this in a time frame that he wishes. So our master treatment plan for John is we're going to do the upper right quadrant in porcelain this year, the upper left in 2011, lower right 2012, lower left 2013, the upper anteriors in 2014, and finish him up on the lower anteriors in 2015. That's something that he can afford to do. Common question. Do these cases last? As long as the three principles are adhered to, they do. They last, and I'll show you some cases. This is Christy. In 2004, she had a lot of worn teeth. She was 22 years old, a lot of headaches, a lot of muscle tension. Oh, someone asked, does John wear a night guard? Absolutely. I make night guards for all of these patients when we're finished with them. Very good question. I would recommend that for every patient. You don't know what medications they're going to be taking. You don't know, what their nocturnal habits are going to be. So, yes, make them a night guard. Here was Christy after we restored her in 2005, and then the lower photograph is 2010. And I had not touched the case in 5 years. This is exactly how she came in 2010 for a cleaning visit. And she was going to move to Portland, so I said, hey, let's get a picture of this so I can, have it. And when you come back in town, let's keep getting pictures. Because I love to follow these cases. There's her composite after we restored her. That's all composite, folks, on the upper picture. Those are composite veneers with no preps on the teeth. And look at them 5 years later. They haven't changed at all. The left excursive after we restored her on the upper, and the left excursive 5 years later. Protrusive, post-op on the upper, 5 years later on the lower. Right excursive. Look at the anatomy on the teeth. Immediately post-op in 2005, and then 5 years later. The cusp tips are still there. The peaks are still there. The valleys are still there. The length of the teeth are exactly the same. Here's the lower arch after 5 years. This case was done in all renamel, all flowable, even the posterior teeth. Because I didn't have Colure back then. Colure's only been out for about a year now. It's a great composite. So 2004 before treatment, 2005, January of 2005, right after treatment, and January of 2010. No change, except for her hair. I'm glad the teeth don't get darker like the hair did. And there's Christy now. Here's a 9-year-old case. This is the first case that I ever did with composite, full mouth case with composite. I did it 9 years ago. Pre-treatment, no anterior guidance. We did do some porcelain on her, but I think we did four crowns and on posterior teeth. Everything else was composite. Pre-op, she was 10 millimeters length on number 9 and 8.5 millimeters length on number 22. After jaw stabilization, we seated her condyles up into the CR position, or the stable condylar position, superior anterior medially. That was her first contact on a second molar. We restored her at that vertical dimension. Here she was in post-op in 2001. And some of these are slides that I scanned in. That's why the picture doesn't look as crisp. But her vertical dimension was 17 millimeters in 2001. 9 years later, 2010, it's still 17 millimeters. She was 10 millimeters on number 9, and we restored her to 11.5 millimeters in 2001. 2005, it hadn't changed at all. It's 11.5. 2010, 11.5. No wear whatsoever. Canine was 10 millimeters. Restored her to 10 millimeters in 2001. 2005, 10 millimeters, and still 10 millimeters in 2010. And you can see her anterior guidance hasn't changed at all in 9 years. There's a little closer up. Protrusive, no change at all. Closer up, you can see the composite. Very little changes in the composite over 9 years. And there's the composite now 9 years old. 2010, these are the lower anteriors 9 years later. And here's Diane at 2001, 2005, and 2010. A few more cases. This case is 3 years old. Before is on the left, after is on the right. This case is now 6 years old. This case is now 4 years old. This case is now 4 years old. 2 years old. We did this case last year. This patient was really sick, really felt bad, a lot of headaches, a lot of muscle tension, and just look at the vitality in her face afterwards. This case is now right at a little over a year old. And we did this case last summer. All composite. We did some composite crowns on our anterior, on our central incisors, and everything else is color. And this is the case that I showed you earlier, where I was showing you how I make my new stent. This is all color as well. He had a pretty severe crossbite on the left as well, and that's why the canine over there is shaped a little bit different. But he functions fine now. And there's Christy again, before and after. I want to thank you all for listening today. If you have any more questions, please email me at halstewart1@me.com. Or if you want to give me a shout, my office number is 972-874-3957. It's been a real pleasure talking with you today, and I hope that you learned some things. I've got 3 minutes left, so let me try to answer some questions. Okay, here we go. Sadim asks, as we know, most of the composite changes its color after 5 to 6 years. How come they don't? I guess you're asking how come they didn't change with these cases. I don't think if composite is polished well and you have a patient who is good with their home care and doesn't have a lot of bad habits like chewing tobacco or smoking, I disagree that the good composites don't change colors. You can polish them. You can maintain their vitality. They do change color some, but it's not as significant as some would think. Peter asks, you have steep guidance in most cases. This would fracture the incisal edges, particularly on cuspids. When you've met the principles of occlusion, you have a stable joint, you have no posterior interferences with the arc of closure, you have immediate disclusion, you do not fracture cusps because the way the stomatic gnathic system works, the anterior proprioreceptive guidance that is created by proper canine and incisor relations is a built-in protective mechanism, and every now and then we'll have a crash on the canines and we'll have to repair it, but it very rarely happens. Which brings up a good question. Composites are very easy to repair. You can do it very easily and inexpensively. But when all those criteria are met, I don't spend a lot of time repairing composites. Believe me, I've done about 400 of these cases, and if they broke all the time, I wouldn't be doing them because I wouldn't want to be spending all my time repairing cases. So the key is satisfying all of those occlusal principles that I told you about. The joint has to be stable, you have to have proper tooth form, and you have to have proper form of the occluded dentition. If you have all three of those, then you won't break the canines, you won't break the incisors. Like I said, occasionally accidents happen, but it's very rarely that it does. There was a question earlier. I'm a hygienist. I need this done for myself. Full mouth reconstruction. I'm only biting down on anterior teeth. However, I have quite a few posterior teeth, which were pulled unnecessarily. Well, it all starts with stabilizing the joint, making a diagnosis, and then rebuilding the occlusion. I see my time has run out. If you have any more questions, please email me or call me, and I'll be happy to answer them as soon as I can. Again, I appreciate your time today. I hope you all learned something, and I'll be looking forward to our next time together. Thank you very much.